Anyway, well, thank you for being here. This is our second in the series of these Lunch and Learn sessions, and we're very excited. This is an event that is supported by the Alumni Association. I also want to welcome those that are on the webcast, especially alumni that are joining us today. We have a great session for you today. Our speakers today are Dr. Ramdas Menon and Jason Phipps, who are part of the Texas Medicaid Health IT team. I'm going to read you a few sentences about them as a way of introduction. Ramdas Menon has served as the Director of Health Information Technology at Texas Medicaid since January 2012. The HIT team is responsible for disbursing incentive funds to Medicaid providers if they adopt, implement, or upgrade to certified electronic medical records. The team also manages a web-based portal, MEHIS, that provides information to Medicaid clients and providers. Before joining Medicaid CHIP, Ramdas served as the Director of the Texas Center for Health Statistics at the Department of State Health Services for more than 6 years. Ramdas has a doctoral degree in sociology and a graduate certificate in public health. He's an adjunct faculty at the School of Public Health at Texas A&M University. Jason Phipps is a consultant for multiple healthcare organizations in Texas, including Texas Medicaid, where he acts as a health IT architect. Jason began his career in the laboratory as a chemist, where he became more involved in the utilization of technology in the lab. This led him into the broader world of health information technology, where he has spent the past 16 years building software solutions for biosurveillance, clinical information exchange, and various other HIT concerns. Today they will be talking to us about transforming our healthcare system with the aid of health IT innovations, progress, opportunities, and challenges. Just a couple more things of logistics. Don't forget about our final Lunch and Learn in this series, which will be on March 24th. We'll have David Fulton from the Texas Health and Human Services Commission, and also an SBMI alumni. He's going to be talking about electronic prescribing of controlled substances. So with that, we thank you for being here, and thank you.
Well, thank you for inviting me. So I'm going to start by setting the groundwork for this. I've managed this program for several years now, and we do a variety of things. And today's conversation is mainly about focusing on what we do. And did you specify which button to press? So
Should be the arrow keys. Let's try the arrow. Left and right.
no.
No?
You just click into the power button.
Let's get it.
Mouse. Yeah,
There we
now.
go. Okay, now it's focus.
Okay, got it. So we'll a high level, 10,000 foot level introduction to Texas Medicaid, an introduction to my team, and then we'll be talking about something called the Clinical Data Innovation Pyramid, electronic health records, health information exchanges, and then in the last couple of slides we will be talking about what kind of progress we have made, where are we headed, what are the pitfalls that we're facing, and all that kind of issues, okay? So I'm going to take the first 10, 15 slides, and then Jason's will take over from here. Okay, this is a 10,000 foot view of what Texas Medicaid is all about. So I assume that you all have heard of Medicaid. It's a huge part of our state budget, right? So as a taxpayer, you should be concerned about that. There's been a rapid growth in Medicaid in the last 2-3 years, and although it's not directly linked to the ACA, because Texas chose not to expand its Medicaid, the spillover effect of ACA was that our Medicaid enrollment grew from about 3 million to about 4.2 million in just about 2 years, right? And a lot of the enrolled Medicaid eligible clients are basically children, and it covers a certain portion of the adult population, especially those who are disabled and pregnant women. All right, so this is what Medicaid looks like. And we had an interesting tidbit this morning when we were driving in. Apparently, if you are an immigrant to this country, you are not eligible for any kind of health benefits, except for one group of people. Anyone want to take a guess at that?
Cubans.
Cubans. When Cubans arrive in the US, they become automatically eligible for not only refugee status, but also into Medicaid. All right. Here are some eligibility criteria: low-income families, pregnant women, children based on income level. So it's basically an indigent population primarily, right? So here are some facts and figures. And we do have what we call a pink book, The reason we call it a pink book was initially when it was a hard copy, the cover pages or the cover was a pink, but now everything is online, so we haven't really gone to the extent of making the online version pink. But basically the pink book gives you a lot more facts and figures of Medicaid right there. This is a good graph which shows you the profile of the Medicaid clients in terms of what the caseload is and what the expenditures are. All right, and you clearly see that 80% of the population actually not are children, but that small group here who are aged and have disability, they account for a huge portion of our costs, almost 60% of our costs. Okay, this unit which I manage, or the department which I manage, was established about 5 years ago. Our primary goal was to drag Medicaid kicking or screening into the electronic era, right? Primarily, all through the first part of the 2000s, everything was done on paper, all right? And then the federal government came out with some policies associated with the ARA, American Recovery and Reinvestment Act, which incentivized electronic health technology. So a lot of agencies which were reliant on federal funding began to think in terms of how to incorporate technology into managing their caseloads and the delivery of services. So CMS, Center for Medicare and Medicaid Systems, basically started incentivizing providers. So the states now had the responsibility of figuring out how best to go about doing this. How do you disperse funds? Who gets the funds? And those sort of issues. So that's why this department was created. Right? So basically our functions cover these following items. One is we administer the electronic health record incentive program. Second, we try to move providers, and these are, there are some eligibility criteria to be eligible for these kind of incentives. You have to have a 30% Medicaid caseload before you become eligible for the incentives. And the first stage is something we call ARU, Adapt, Implement, and Upgrade. And then you have Meaningful Use 1, Meaningful Use 2. So in addition to dispersing these incentives, we are also figuring out ways of how to move the people along the continuum from ARU to MU1 to MU2. And that has been a challenge for a variety of reasons. I think most importantly because CMS, which is the federal government, has never been clear about what are the standards, what are the guidelines. So, there's a lot of wiggle room, and lack of clarity at the policy level always leads to some negative downstream impact. And one of the things we've noticed is people were not moving as fast from ARU to Meaningful Use 1 and 2. That's one of the factors. The other thing we also do is we're also thinking creatively of how do we get the data into all these EHR systems. One of the problems is we have in healthcare is basically you have a situation of silos. Primarily, until a few years ago, everything was based on paper-based silos. Now, we're creating a system where there may be thousands of electronic silos. So we got to figure out a way in which the silos are connected to one another and there is information exchange. And that's essential for two things in healthcare. One is transitional care, the other is continuity of care. And here are three goals that we try to this is one of the things we came up with as we began to develop a philosophy around what HIT or what the HIT department is supposed to be doing. We wanted to kind of move Medicaid towards a population-based approach that is based on risk profiles. We want to improve the quality of services which were delivered, and we wanted to actually improve costs. And we felt that basically HIT is a catalyst and a facilitator to progress on these three fronts. My team itself is a very small team. We have about 10 people. We come from a variety of backgrounds. We have a physician who actually now does policy for us. We have one of your alumni, David Fulton, who is actually managing our outreach efforts. All right, and we have Jason, who will be presenting after me. He is our technical architect. We have project managers. What we try to do is we made it a point to recruit people from diverse backgrounds so that we have more energy and ideas at the table when we have discussions. So it's a fairly intellectually stimulating environment to work around or work in. So that's one of the things they've done. And this biologist who's got applied tech lab experience, who's this?
It's Deb.
That's Deb. I thought it was you. You're a chemist, right? Okay. So one of the more exciting parts of my job, or our team's job, is basically that we not only sit in a room together and figure out how to determine or interpret CMS policy, we also have built an analytical platform. So a lot of our work and policy development is based on analysis of data. And Jason will be going into that in a little while. The other thing we also do is that we do surveys. We figure out what's going on in the field. We survey a lot of the managed care organizations, which actually now administer 80% or 90% of services to Medicaid clients. We also go out into the field. In fact, right after this discussion, we're going to an ambulatory surgical center, an outpatient clinic, just basically to talk to people, physicians, clinicians, just to get a sense about what's going on out there. What are the barriers? What are the issues that we are not aware of? So that would help us educate ourselves and fashion the way we develop policies and interventions. So that's one of the more exciting parts of our job. The other thing I wanted to mention is that we also manage a portal. We, meaning my area, also manages a portal which basically targets Medicaid providers and Medicaid clients. So that portal was conceptualized and developed sometime in 2009, 2010, at a point in time when EHRs were just beginning to emerge. And then all of a sudden we have a fully fledged portal on which we spent millions of dollars. And we're trying to roll it out, talk to providers, understand what's going on. So I've learned a lot about what are some of the challenges in engaging both the provider community as well as the client community to use technology or portals or EHRs. And one of the things I've learned is that you have to work really, really hard at it. That education and outreach effort is a major, major component in whenever you roll out technology in the healthcare arena. And with that, I'll have Jason take over the rest of the presentation. And we'll both come back at the end to deal with the conclusions.
So for this part of the presentation, I'd like to take you on a little trip through where the data goes. So we're the EHR experts. We run the incentive program at Medicaid. So once you get the data into the EHR, then things can start happening. Before, when everything was on paper, data was trapped or data wasn't being recorded at all. So what we've come up with here is I've taken a cue from a famous graphic that shows basically the development of knowledge and wisdom. It starts with raw data, and then you go through some different stages, and you end up at the top with actual actionable wisdom. Well, the same thing applies in our field. We start off with the data in electronic health records. The incentive program that we run is mostly focused upon getting that data into EHRs in a way that it can be used further up the pyramid. You can say you went electronic simply by sending something via fax. A fax is electronic, but a fax is not anything that can be really put to good use at the other end. There's no structured coded data that comes out of that. So a big part of the EHR incentive program is what we call meaningful use. It's meaningful use of electronic health records, not just a copy of your old paper system made electronic. So if we can get the data into EHRs, then we can pull it up using health information exchange. So we have to get this data that's locked into these practices in hospitals and pull it up into HIEs where it can then be pushed forward to people using it for things like analytics and care coordination. This is where the real innovation happens here. So you have a very limited group of people that are involved in designing and implementing EHRs. The same story with HIE is very small, limited sliver of the healthcare information technology team. This is where everyone else in the world of healthcare gets to work with the data and innovate. And that's really, we see our jobs on the team, we're mostly focused right here, but you'll see as I go through some of the examples of what we do on the team, you'll see that we have a few cutting edge things that we're doing in this area, kind of trying to lead the way for Medicaid, to show Medicaid what the future looks like. Because we're the experts in these things here, it's natural that we do some of the first things up here that involve the use of this data that's bubbling up. And then I put payment reform at the very top. There's actually a few different things that you could put there. But I put payment reform because for us at Medicaid, we're basically a big insurance company. So for us, payment reform is a huge deal. You know, in the past, we simply did what was called pay and chase. Someone sends us a bill, we call it fee for service. They send us a bill, and we just pay it blindly. We don't know really much of what happened. We don't have details on that encounter. We're really just trusting the providers to be honest and tell us what's going on. We don't know what kind of quality of care the patient got. We're paying the same rate to every doctor, no matter what the outcome is for the patients. Payment reform, and you'll see some mentions of that further on in the presentation. Payment reform allows us to start changing that. And it allows us to start paying for the quality of care that our patients get. And once you really get into the idea of payment reform, you look back at what we used to do and still are continuing to do to a certain extent, and it really starts seeming silly. But we had to do that because we didn't have all of this behind us. But now that this is emerging and we can hook this up, now we can start doing things like payment reform. So let me tell you a little bit about the Electronic Health Record Incentive Program. We're not just eliminating paper records and replacing them. It's much more than just a replacement. Obviously, there's improved accuracy. One of the biggest things, especially for someone like me, is that there's data standardization and networking. You know, these are the kinds of things that, if it happens at the EHR level, can push things up to that HIE level and beyond. One of the examples that I use about the really cool stuff that's in EHRs nowadays is clinical decision support. And what this is, it's kind of like artificial intelligence built into an EHR. Now, I say artificial intelligence, that's really kind of the promise of it. If you look at an actual EHR today, it's not as slick as what you would usually think of as artificial intelligence. But in some very vertical experiments around the country, they are starting to hook people's EHRs into larger data banks and processing systems. So everyone's heard of IBM Watson. You know, the IBM folks are doing this. They have large sources of data to which they're hooking Watson into, and they're actually having providers using EHRs that get advice from Watson in real time while they're actually within an encounter with a patient. In addition to these, there's many, many more advantages, some of which we'll go over in just a moment. So before 2009, when we had legislation come out kind of mandating, incentivizing, pressuring providers to adopt EHRs, the healthcare industry severely lagged other industries. And this is not just in EHR adoption, it's in adoption of a lot of things involving technology. 2006, only 11% of ambulatory office-based physicians reported use of something, just a basic EHR. Well, luckily, we're up to 70% now. A lot of that due to the incentive program, and actually have some good statistics to show you the effects of the incentive program here in a second. So in general, the lack of technology has hindered reform in the industry. We saw the pyramid where we had payment reform at the top. We haven't been able to do that because we've been missing the lower levels of the pyramid. This was all started in 2009 as part of the Recovery Act, the stimulus funds that went into the economy at the beginning of what people call the Great Recession. What the money that we're paying out right now to providers and hospitals is for this incentive program, the money that we're using to stimulate the creation of health information exchanges. All this money comes from that stimulus funding that was enacted back in 2009. We're paying incentives for healthcare professionals and hospitals to use EHRs in a meaningful way. As I mentioned, we can't just be a copy of what's done on paper. We have all these new requirements where you use EHRs to power innovation. As far as the incentives themselves, the Medicaid program, there's also a Medicare side of this run by the feds. The Medicaid program is much more generous. For example, we do 6 years of payments. You can skip years. You can do your first year this year, and you can wait a couple years and say, okay, I'm ready to move forward. The requirements for the program get a little more stringent every year as you go through the program. We have 3 main stages of meaningful use. For a good example is our EPrescribing measure, which starts out at 40% e-prescriptions in stage 1 and moves to 50% and then onward as you go through the stages. a total of almost $64,000 over your 6 years of payment. And that's per provider. So if you have a practice that has 10 physicians in it, then you can use that as a multiplier to see what kind of funding over those years that practice as a whole could be pulling in for moving through our program. They have to be certified EHR systems that when people apply to us for incentive payments. We have standards published by the federal government. These things like clinical decision support that I mentioned have to be built into the EHR. The government certifies the EHRs once they see that they've built these different functionalities into the EHR. When you come to us as a provider and you want payment in this program, you have to show us that the EHR you're using is one of those certified EHRs. It's the Office of the National Coordinator for Health IT that actually conducts the certification. Because these federal regulations exist, it's strongly influenced the design of vendor software. The guidelines that we're looking at for meaningful use include a lot of structured data capture, a lot of things that pertain to health information exchange, public health reporting, like reporting vaccinations to our registry at the state health department, and a lot of other improvements. We score the providers according to their performance on the metrics. We have a minimum score on each of our metrics. For example, in stage 1, we have 25 total metrics. 15 of those are required core metrics. The other 10 are a menu set from which you have to pick 5. For every one of those, we have a threshold. Once you meet the threshold on every one of those measures, you can apply to us for funding, and then we'll pay you an incentive payment for that year.
And we audit them.
Yes, we have to, and we do actually require records from people's EHRs, and we will look at all the prescriptions that were sent and make sure that when you say you did 40% e-prescribing, you really are doing 40% e-prescribing.
I can attest to that. We've been audited several times. Same here on the ambulatory side.
Well, I hope if it was for a Medicaid audit, it was an acceptable experience. I'm not going to say good experience, acceptable. So examples of our data capture metrics. And this is so simple. I mean, the fact that we have to have these kinds of metrics is a little telling. You know, it tells you where we were before 2009. So any orders for medications, lab tests, or radiology must be entered electronically. Here's a real simple one, patient demographic data. We're talking birth date, we're talking addresses, ethnicity. This must be stored electronically. Certain of these fields are actually required in our regulations. We actually name the individual fields. That we have to do that is really amazing. Now, 5 years later, 6 years later, it's commonplace. But back in 2009, this actually had to be written into law. Diagnoses must be kept electronically and must be recorded as structured coded data. And this is where we come back to that pyramid. If EHRs recorded diagnoses simply as free text written in, with a keyboard by a provider, that data is useless outside of that practice because everyone's going to write different things. They're going to abbreviate diagnoses differently. We have to have structured coded data to cross that barrier between EHRs and HIEs.
So can I ask you a question back? I'm not sure.
Go ahead.
Can you go back to that?
Sure.
So that the last bullet on there, you said structured data, but the two prior both supplements, it says just electronically. Does that mean that they don't have to be structured for those two, or?
No, good point. The demographic data, for example, the federal government publishes a ethnicity coding set. And in the federal regulations where it requires these certain fields, it will refer to the code set to be used for those fields. Now, so this is a good example. I talk about semantic interoperability. I mentioned this in a few slides. I'll just go ahead, and in case I forget when I get there, I'll point out that one of the fields, birth date, this is a issue with semantic interoperability. There's a lot of ways to represent a birth date, and the federal guidelines fail to specify an exact way to do that. So right now, we still have a problem with EHRs forwarding to HIEs birth dates in many different formats. So you have engineers at all these HIEs, they're literally sitting there for every individual connection that gets hooked to the HIE, and they're watching what comes over and they're reformatting it into a standardized way that they can use in their HIE. Now, then it begs the question, is every HIE reformatting that field the same way across the country? And the answer is usually no. And so then there's another standardization problem that gets introduced to the system. Examples of health information exchange, meaningful use measures. The transfer of immunization data from the EHR to the state immunization registry. We also require reporting of electronic lab results, and in this case, the code set specified is LOINC. We require healthcare providers to provide an electronic copy of a patient's health record to a patient upon request. And this is a very interesting measure. We have exceptions for physicians. Physicians can say, well, you know, nobody ever asked me for their record. And in fact, if you look through our data, almost every single one of our thousands of providers have actually attested that this has never happened. I'm not sure what to believe. You know, I hear my friends, my parents, others talk about how they desperately want to be able to carry their healthcare record with them, take it to their specialist. I hear this demand from patients, but yet I hear from providers that nobody ever asked. So this is one of those things that our team, you know, we do surveys out in the community and outreach. This is one of those items that we're very curious about, and we want to find out more about in the future. Some basic stats on the program: we have 335 hospitals around the state involved. These are, you know, mostly your bigger hospitals with emergency departments. We have over 8,700 individual physicians now, which are, you know, when we say individual providers, they're mostly ambulatory. They may actually, they're not, you know, in a single practice. They may be in a very, very large practice or attached to a hospital. But we divide up the program between actual hospital organizations and the individual physicians. In total, we're getting up towards $800 million now, given out since 2011. The program runs till 2021. Participants, they continue to progress through our different stages. We're really at stage 2 right now. We haven't opened up stage 3 yet. But you can, this year is the last year that you can start participating in the program. So it ends in 21. So if you start now, you can get your 6 years in without skipping years.
So this is new to me, but I really want to learn a little bit more. So 335 hospitals. What about the TMC or Houston area? You have some idea which kind of proportion of the hospital in Houston area, for example?
What proportion?
Yeah, this incentive program.
I'd say there's a good many of the hospitals in Houston. Yeah, I certainly can't tell you.
Do you know Harris County Psychiatric Hospital? You know, I just came from there, so I really want to know because we also need to apply the EHR, so there are a lot of programs.
Now, I could tell you, I think I can tell you that the psychiatric hospital is not in our program because we do have certain eligibility requirements for both providers and for hospitals. And behavioral health is definitely, there's a big gap there. When the federal regulations came out, they pretty much excluded any kind of psychiatric hospitals or behavioral health providers from the program. And there's been a great controversy over that because if you look in the industry, in 2009, the people that were the most behind with the application of technology were exactly those types of providers. And they're still behind. So you have to kind of wonder, when they came up with this legislation in 2009, did they look at that and say, these guys are just too far behind, we can't include them with the rest of the pack? I'm not sure exactly, you know, how that happened back then, but we are actually starting to put some more attention to that. We're hoping some federal regulations come down that will allow us to expand the programs to those types of providers. An example of something that's working really well for us in the incentive program is the EPrescribing measure. I mentioned that stage 1 requires 40% of a doctor's prescriptions be done via EPrescribing. We love EPrescribing. EPrescribing has something good for everybody: patients, providers, payers like us. It reduces abuse and fraud. It's more convenient for the patients. It allows you, it's more safe for the patients. It allows you to detect things like possible drug-drug interactions. So how are we doing? What is the incentive program doing for this practice? Well, you can see here, we took tens of thousands of Medicaid providers that are not in the incentive program, and we measured how they prescribe their drugs. And so you see over a few years here, 11, 12, and 13, we've got 13%, 20%, and 25%. So the rest of the Medicaid population, they are moving forward a little bit. They're starting to e-prescribe a little bit more. But look at the stark difference. This is the collection of thousands of providers that are in our incentive program. These guys were doing 36% in 2011 versus 13% for the rest of Medicaid. Then you get over here to 2013 and it becomes even more stark. We're now at 63% for the people within our program versus 25% for the Medicaid providers that are not in our program. So not all providers qualify for the program. As Ramdas mentioned, you have to have 30% Medicaid volume. One of the opportunities that we see is expanding this program. You know, maybe we can, those Medicaid providers that you saw that are doing much worse on e-prescribing, maybe we can find a way to get them into the program and we'll see their rates rise accordingly. We also need to get patients more engaged. One of the measures, the most hated measures that I hear about from providers is that we require that providers have a portal for patients to log into. Providers hate this. They always hear, our patients don't know how to use the internet. I hear that from providers that serve several different groups of patients. They seem to think that their patients know nothing of the internet. And then another one I hear is that their patients just don't care. And this kind of harkens back to the, you know, how they say patients don't ever want an electronic copy of their record. I'm not sure I believe that. The anecdotal evidence I get from the people I know tells me different. So definitely a big opportunity to try and get providers to use this technology and get patients to really demand it. You know, if patients really know what they can get, maybe they'll demand it, maybe they'll use preference and choice to navigate the healthcare system in a way that makes providers think they should get with the program. Other opportunities, federal regulations include a requirement that all EHRs be capable of generating lists of a provider's patients by diagnosis. So this very small sounding measure here actually can have great impact if implemented correctly. The problem is the federal regulations don't go far enough to show you what to do with this functionality. So you're guaranteed, if you have a certified EHR, to have this functionality. It doesn't mean you're actually going to use it for good. But what can you do with it? You can create lists to target certain patients. You can look at all your diabetics, and you can take this list of diabetics and you can hand it to your office staff and say, call them every 2 weeks and make sure they're taking their medication. Lots of other different care coordination opportunities once you can pull together the people within your panel that have certain needs. Challenges in the EHR incentive program, definitely providers' resistance to change. I don't care what you're asking a provider to do. It could be totally for their benefit. They're still going to resist the change. There's also oftentimes a necessary redesign of existing practice workflows and creation of new ones. So not only a personal resistance to change there, but also a monetary hurdle. You know, anytime you're going to change around how a practice works, there's education, restaffing that has to occur. So definitely monetary hurdles there. Vendors' desire to please providers and make sales causes EHRs to mimic old paper processes. So because providers are resistant to change, EHR vendors, they take the rules that we give, and sometimes those rules don't look like they've really been translated well into the software itself because the EHR vendor wants to sell the software. And a lot of times they're talking to providers that want as little change as possible. They actually want to see their manual processes simply copied into electronics. And then, like I mentioned, the lack of specificity in rules coming from the federal government allows for less than ideal interpretations and implementations within these EHRs. So a challenge here that I can show graphically within our incentive program that we run. Notice here that there's some suspicious spikes here that happened on January 1st. That's 2014, 2013, 2012. These are the biggest spikes here. The reason this is trending down is because this is a rate of change analysis. What we were looking at is how quickly are providers adopting e-prescribing. It's not a problem that it's going down because obviously when you start from 0% and you go to 5% people prescribing, that's a big jump from 0 to 5, but 5 to 10 is a little bit smaller jump. And it takes longer to get from, say, 30 to 35 than 0 to 5. So you're going to see a downward trend. But it's these peaks that really surprised us. So we got into it and we said, why from December to January are people really, really doing better at e-prescribing? And what we found was that during the 90-day reporting period we use to judge these providers and do the metrics, they're really hitting the e-prescribing. So because you have to have 40% to pass. So what happened was in the 2 previous months, they weren't really e-prescribing a whole lot. December comes along, they're like, oh wow, I got 30 more days left in the reporting period. They're really doing some heavy e-prescribing. So we took the 90 days of the reporting period plus the next 90 days, and we measured it. This histogram shows all the providers. Each bin is a bunch of providers. You can see the quantity of providers over here. Each bin shows how much worse they did in the next 90 days. 0% change is right here. That means that everyone from here over did worse. So they did really good on the reporting period, and then the next 90 days, these folks dropped off. These guys out here did 70% worse. That's pretty bad. So obviously, when you run a program like ours, there's a lot of challenges in just, you know, the psychology and working with these practices, trying to make sure that these practices stick. So moving along in the health information exchange, let me check our time here. It's 12:07. I think we're back on track here pretty good. So health information exchange, you know, it allows patient clinical data to be shared between providers, patients, and legally authorized entities like Medicaid. We have a right to this data under HIPAA because of what we call TPO and treatment, payment, and operations. Payment and treatment comes into play for us. We're an insurance company. So under HIPAA, insurance companies have a big right to this clinical data because we're supposed to be using it to try and provide better care and transform healthcare. HIE gets the data out of the EHRs to other systems that can make use of it. The HITECH Act funded development of HIEs across the country and here in Texas. We had $28 million that started back in like 2010, handed out to our state level HIE plus our local HIEs, which you have one here in Houston, Greater Houston Health Connect. That grant ended a year ago, but Medicaid itself, our team has been pulling down money from CMS, and we're about to start creating programs to help stimulate those HIEs again. We have a collection of regional HIEs and a central coordinating HIE. We call this a network of networks. And this is kind of the ancient history of HIEs here. This is how it started out. This is the map from a few years back. Unfortunately, this kind of tells a bit of a story. If you were to update this map, a lot of these HIEs wouldn't be on here anymore. So there's a lot of reasons for that. I mean, sometimes consolidation can be a good thing. Unfortunately, some of these areas that used to be covered and have people providing services, they aren't covered anymore. So we need to fix that. So if you're going to have consolidation, at least the people that are still there need to expand out. We're probably starting to see some of that. Definitely, we're definitely in the infancy of health information exchange. So this is basically the network of networks. We have a federal exchange that our HIE Texas, our state level coordinating HIE is connected to. Medicaid will connect into HIE Texas eventually, and we'll be able to then take data from further down the network, from the regional HIEs who are then connecting down into the hospitals and the ambulatory EHRs. The classic HIE model is query-based. I have a patient that I have in for an encounter in my practice. I take their information, I put it into a query application. It goes out, it talks to my regional HIE, like Greater Houston Health Connect, and it says, hey, do you have any information on this patient? Greater Houston may say, no, I don't see anything in my records, but you know what? Let me check with the state HIE. Then it forwards that query up to the state HIE, and it looks in its records and it sees, you know what? This patient used to be in El Paso. There's records out there for this patient. Would you like to see those? And so then the physician can say, yes, bring back those documents. They go from El Paso through the state level back down to Greater Houston Health Connect, and they're then delivered to the provider. This is our network of networks. Adverse drug events are a great example of how health information exchange helps out. And actually, that's the highest demand we have from providers for HIE. When you ask providers, what's the first type of data you want to be transferred into your practice for your use? They say medication history, because they want to try and prevent drug-drug interactions. issues with drug allergies and overdoses. HIE provides that medication history, makes it readily available throughout one's provider community. So it's like it's the health record that follows you around. And if you're someone with drug allergies, that's probably a really nice thing. HIE assists the providers in putting together these puzzle pieces of a patient's medication history, because patients don't just always see the same provider. They go to many providers in the community, and they could be prescribed the same thing in 3 different places. And a lot of the overdoses that we see are people that are taking prescribed meds as told by their physician, but they got told by multiple physicians, and they're actually taking too much of the same thing. If used correctly, HIE and EHR also know about patients' allergies, and they can use both data types in tandem. This goes back to the clinical decision support that I mentioned earlier when talking about EHRs. The more data that you can get into an EHR, the better clinical decision support can help out the provider. Adverse drug events, definitely an area of health IT that you can get cost savings on. Research shows that $3.5 billion are charged to our healthcare system every year because of adverse drug events. It causes, across the country, 1 million ED visits and 125,000 hospital admissions. Opportunities in health information exchange, one that I'm really thinking about a lot nowadays is that we have to start doing a bottom-up approach, because what we started doing years ago was we had these federal regulations come out, and we said, providers, you need to use HIE. HIE is a good thing, you need to use it. But we were very general about it. We didn't tell them exactly how to use it. So it kind of, it's, in ways it's fell on deaf ears, and a lot of people that have met our requirements have done them really just to the letter of the law, and because we didn't really give them great reasons to do it. So we need to start creating the use cases, move it from the bottom up, create demand. Our DSRIP program, you can go online at our HHCC websites and read more about the DSRIP program. It's basically billions of dollars a year going into the healthcare system here in Texas to do a whole array of innovative projects. That a lot of them that use data and can benefit from more data coming from EHRs and HIEs. I would encourage you to go check out all the different projects, and they're all listed online at our website and with descriptions. One example that I've toured here in Houston is a nurse helpline. But this nurse helpline has no data on the patients. They have no connection to HIE. So we're hoping that in the future, a project like this, where patients are calling into the nurse helpline, those nurses will be able to query for information on that patient right there when they're talking to them, and be able to have that record in front of them. That obviously would be a great help and make that a more efficient service. Also, generation of use cases by payment reform mechanisms. Here we are, Medicare is penalizing hospitals that have too many readmissions for certain reasons. They're actually taking money away from hospitals for these readmissions, which makes sense. But we need better clinical data coming from EHRs to make these decisions about payment penalties. Right now, we're just doing it off of claims, which isn't really that credible. Those equations don't work very well. You need the detailed clinical data to really figure out why someone was readmitted. Challenges in HIE, definitely a lack of maturity in the legal underpinnings of HIE. One of the easiest ways to describe this is that the legal staff are slow to adopt new best practices. So legal staff are afraid of transferring data. Years ago, you went to a hospital and you said, hey, I'd really like for you to transfer some data to us for the use of public health. We're covered by the legislature and law to get this data from you. Would you please share it? And they simply wouldn't. They'd refuse, because they couldn't imagine taking patient data and moving it outside of their enterprise. The legal liability to them was just too great. That's starting to work better now, but it really is still a great challenge. Vendor lock-in and data blocking is a huge challenge right now, especially with ambulatory EHRs. Basically, in the industry up to recent years, an EHR vendor wants to not only supply you with your record-keeping system, if you want to do analytics at your practice, they want you to buy an analytics package from them. They want you to buy a care coordination package. They want you to buy the patient portal. They want to supply everything in any ecosystem you would want to take advantage of. Well, the easiest way to keep people buying your products is to make sure that your data in the EHR can't get into a third-party product. So if there's another care coordination software that you want to use, you can be prevented from doing that simply by your vendor making sure you can't export your data over to that application. Providers' fear of measurement is a problem. Remember, payment reform requires we measure providers. We can't measure providers without having the data from their EHR. So if they can prevent that data from coming out of the EHR, they can keep us from measuring, thereby keeping payment reform from happening. We talked about semantic interoperability being a challenge earlier, and basically enforcing standards via regulation isn't working out great. It probably could if we redoubled our efforts at the federal level and tried to get a little more specific with the regulations. So our last section for the pyramid is analytics and care coordination. This is what we can do once we get the data into the EHR, up out of the HIE, and into the hands of all the different people in the healthcare system that can create innovation. Analytics receives data from HIEs, creates the metrics by which payment reform can be accomplished. We like to pay for quality care and outcomes, and this is the classic example we use about payment reform here, that it's foolish to pay a hospital for a patient's readmission to treat a hospital-acquired infection from the first admission. We're rewarding a hospital for giving a low quality of care the first time. And in the old system, as many times as that patient comes back to the hospital, we keep paying them. And it seems ridiculous on its face nowadays, now that we have these ideas of payment reform, and we actually have some hope of doing them because we have EHRs and HIE. So that's what we're moving towards. Payment reform is making sure that we're reforming the healthcare system, and people are trying to give that quality of care, and they actually feel that in their pocketbook when they're not supplying that quality of care. So how well is a provider caring for a diabetic patient? This is on the ambulatory side. Our foot and eye exams performed regularly. Dietary counseling provided. So with EHRs and HIE, we at Medicaid, we can actually look and we can see what's going on with the care of that patient. We can stratify providers. We can say, you know what, we want more of our diabetics going to that provider because they're really doing the right things. Their outcomes are better than these other providers. So if we can see the details of the care patients receive, we can automate review processes. So we don't have to do this on an individual basis. We can actually create IT systems that use things like artificial intelligence to figure out who those best providers are. Who are the patients that are most likely to become diabetics next year that need some extra attention. Care coordination involves the use of data generated by EHRs and HIEs to achieve the triple aim we were talking about earlier. So care coordination can utilize analytics, but is also a little different. Here's one project where I can kind of sum up what care coordination is. This is the emergency department event notification system. This is a project that our team is building and funding. The goal is to enable care coordination strategies, such as, and this is the principal one, primary care physicians being able to follow up after a patient goes to an emergency department and keeping patients from hitting the emergency department in the first place. Research has shown that if a primary care physician gets in touch with a patient that entered an emergency department within 72 hours of them leaving that emergency department, it's much more likely they will not return to that emergency department for in the same episode of care within like the next week, next 2 weeks. That reduces cost and it gets the patient more appropriate care. Maybe they need to be somewhere else in the emergency department to get better care. So we're actually going to ask hospitals to start donating data to this program. Hopefully, we'll actually have some regulations come out that require the few hospitals that will refuse to join the system. Hopefully, this is going to reduce readmissions. We could even have things like proactive delivery of care plans and other HIE resources, getting to the EDs. The way it works, we're basically asking for the ADT data. If anybody knows HL7 and the ADT messages in HL7, we're asking hospitals to send us that. We're looking at the ADT data, at the people being admitted, and looking at our records in an automated fashion to figure out who are the Medicaid clients. And then we send messages to our managed care partners that are responsible for helping us take care of these patients. So the opportunities that we have, I'll just run through these real quick. We talked about a lot of the analytics that we can do. We talked about the care coordination. Some of the challenges, The biggest challenge, gaining access to the clinical data. The HIE and the EHRs, you've heard us talk today about some of the challenges that we have with those two elements within that pyramid. Those aren't going away anytime soon. It's going to be a hard fight over the next years to get those things perfected, to get it where the clinical data can come up to us and we can do things like analytics and care coordination. And here I'm going to turn it back to Ramdas, who's going to look at the conclusions for us.
So basically the bottom line is that IT is a panacea. It can facilitate and promote, serve as a catalyst. But there's going to be a lot of pushback in the populations we deal with, and I see the biggest problem as engaging our clients, the patients. And that's an important component. We haven't really done a good enough job of educating our clients that it's their data. They don't have to go through duplications of tests or procedures or something of that nature. So that empowerment model has not been applied to healthcare. That's number one. The second thing I wanted to point out is that, okay, this has been a period of very dramatic change, maybe in the last 4 or 5 years. But, when we move, so I think we are in the middle of a paradigm shift. Previously, we never thought about using data the way we're using data in healthcare right now to facilitate a lot of activities in healthcare. But now there's an increasing acceptance that data is important, and people are trying to figure out things. But when you're in a period of transition, and when you start a transition, you always overestimate the benefits within a 2 or 3 year time frame. But you always underestimate the benefits which come in about 10 years. So we are now in the middle of this shift. We expected more, but nothing. We're seeing some signs of hope, but it's not there yet. All I can say is be patient and persistent. We're in the middle of a change. It'll take some time. So we're still putting together basic elements for the infrastructure. There's need to work on governance structures. We need to get more important data flowing through HIEs. I think we've taken a giant step in the last few years, but we need to really keep persisting and be patient about achieving the ultimate goals, which is a more efficient healthcare system. 16% of the US economy, right? GDP, in terms of GDP, and probably worse outcomes than some of the other countries in the organization or the more economically developed countries, which spend less but have better patient outcomes. That's where we are at right now. So I welcome questions at this point, and suggestions, ideas.
So you mentioned getting patients involved quite a few times, and I actually listed that as one of the key issues with the electronic health records or the information exchange. And so what I end up seeing is a lot of incentives being provided to providers. But have you guys ever considered taking incentives for patients to actually use their health records? And the assumption to make a comment about it being an issue is that there's some benefit either in health or cost for patients to actually do it. So any thoughts on incentivizing the patient to do these somehow?
Well, I manage a portal directed towards Medicaid clients, so we do surveys. And what we have discovered is even in the indigent Medicaid population, mobile platforms are important now. Access to internet is almost 80% among the Medicaid clients we're looking at. So we need to think in different ways. Some may still rely on the old methods, so they want a paper printout, right? So we've got to think in terms of blue button, which is one way you can deliver that to somebody who requires something in paper. The other ways is we have to, basically the bottom line is we probably do have to do a lot of hand holding. It's one of the meaningful use measures that the providers don't really like, which is give a record to a client. And that's the reason is we really don't have the patience or time within the workflow setting to actually handhold the patient and say, establish an account, sign up. But what we are seeing on the client side in the Medicaid portal is signs of hope. I mean, the numbers using it have gone up despite the rapid growth in the Medicaid population. And when you deliver more services and through the portal, they are more likely to sign up and remain engaged. So I think it's really boots on the ground kind of situation where you really need to spend a lot of time. The other thing we need to we're thinking of is developing a website catered towards propagating some of the goals of HIT to the general population so that people can sign on and figure out, well, here are things that we could do ourselves. Because, it's important that we are talking to a community of engaged stakeholders here. You all have parents, you all have family who are at some point or the other likely to encounter a healthcare system. all right? And it's also our role as stakeholders in the system to actually educate the people we come in contact with about some of the benefits which come from having all your records accessible electronically, whether you're in Florida or whether you're in New Mexico. So I think we need to do a better outreach efforts, both informally and formally.
If I may add to that answer, from a hospital perspective, like we are bound by this Medicare program for incentives and adopting EHRs. Now that we're there, that we have the basic platform, we look at technology, EHRs and portals as a way to keep our customers engaged with us. So we haven't done a good job of creating portals. We haven't done a good job at having the patient access the record. But now there's a big push, at least from the private industry, to make sure that we have the best portals, we have the best tools in your phone to make sure that you're engaged with us as a hospital. And to create that experience, not only when you're sick, but when you're healthy too. So we're looking at your Fitbit, at your data, making sure that you have a place where you can log in and share with us, and we can share support for how to improve your health and so forth. So from our hospital perspective is we're using technology to try to capture a population of patients that not necessarily is sick, but that eventually will require our services. So I think your point is well taken.
Yeah, I want to reiterate it too, though, because I'm not quite sure I got it across. There's an assumption that you can connect patient access to their electronic records so when patients access their records routinely, they're less likely to go to the hospital unexpectedly. So you could actually quantify that somehow in monetary sense. I mean, that's kind of the underlying assumption. And if you could do that, then maybe and I don't know the answer to this, it's just me listening to you guys now. It's an interesting question of whether you could actually incentivize patients to do that, if there's a benefit somehow to do that. And I'm talking about the same that you do for providers, so monetary incentives or other things for patients to actually use the records.
Well,
Go ahead.
I think you will see this on the commercial insurance side.
Yes.
This is highly unlikely to happen with Medicaid because it's a politically sensitive issue. I mean, Medicaid is free insurance. So politically adding on top of that with monetary incentives would be very unpopular. But I certainly agree with you.
I shouldn't just say monetary incentive, but some sort of incentive, though.
I certainly agree with you that the patient engagement can translate directly into saved dollars. Having the person that's actually going through the experience actually watchdogging what's going on. If a patient gets sent for MRIs twice for the same area, if that patient's more engaged rather than passive, they might actually tell their insurance company about this. They might actually complain about it. Private insurance companies would love this. So I have to imagine that somewhere along the line here, as patients have the tools through these kinds of technologies to get more engaged, that maybe commercial providers will take advantage of that.
A right population would be diversion from emergency room visits.
Yeah.
That's a good population. So if you have a history of emergency room visits and somebody intervenes, a case manager intervenes and figure out what's going on and take care of the daily needs and identify symptoms that the patient is likely to report, which leads to ED use, we could probably intervene and reduce visits to ED rooms. And I think there have been a number of projects which have successfully implemented ED diversions. That have.
Were you thinking along the lines of, I know, for example, a couple of insurance companies that we work with are actually offering checks for $450 to patients if they log in every month and enter their Fitbit data, and they actually achieve some goals. So you pay your insurance and you're actually getting money back for using these tools.
Yeah, I don't have a specific workplace I was going, which is interesting, sitting here thinking about the question when you start talking about that being part of one of the major issues. Let's just say that you thought because patients were engaged again, you could save $5 billion a year. Then to take $1 million and provide some sort of incentive for people to do it would be in your best interest. That's really all. It just sounds like an interesting thing to do.
I think one of the things we also need to realize is that we have a 24/7 economy, right? But our healthcare system is still 9 to 5 pretty much. So there's a disconnect there. People hold, a lot of people hold multiple jobs. They get home, they have a child who's sick. Guess what? Where do they take the child at 10 o'clock at night? An ED room, right? Why? Because nothing else is available. So, we have to really create a healthcare system or move towards accepting the fact that we have a 24/7 economy, that people are working in the middle of the night when the rest of the healthcare system is asleep.
Yeah. So who wanted to collaborate with your organization?
Yeah, sure. Any other questions? Let me check the chat line.
You know, we work with a lot of providers that are still in the incentive program, and there's a lot of anxiety with regards to MIPS. You know, when Slavitt first produced the announcement, and it was pulled back by Karen DeSalvo with regards to what's going to happen to the incentive program on the Medicaid side. We know that MACRA per se did not really go into the Medicaid side, but what are you hearing in terms of changes on the MIPS side, and is it really going to not have any impact on the Medicaid?
We're hearing there's not going to be much impact on Medicaid.
Okay.
The only impact might be superficial in messaging. The Medicare side, of course, that will reorganize, but the Medicaid side, what I've heard is that there's not really a lot of options to change it because of the legislation. So they have to keep going by the legislation. So they have competing legislation superseding that modifies Medicare, but nothing to modify Medicaid.
Jason, I have a question for you from online. Have you considered any public health use cases such as electronic reporting of notifiable conditions or chronic disease surveillance?
So within meaningful use itself, we have several public health measures. So mentioning surveillance, we have one that's just for syndromic surveillance, and it has been optional up to recently, but it's in that menu set that I talked about of things that you can pick from to complete out your measures. So syndromic surveillance, where people are sending just basic reports of who's entering emergency departments, is mostly for hospitals. We don't do syndromic surveillance on the ambulatory side here in Texas yet. But it's a lot like the Eden system I was talking about, except for the Eden system actually has names and such attached to the admissions. In syndromic surveillance, you only have the chief complaint that someone gives when they enter the emergency department, plus some de-identified demographic information. So basically, if there's some kind of outbreak of something, you start seeing similarities between ED admissions around a region, and we have mathematical algorithms that look at that in real time, and will then throw alarms and send them to our epidemiologists at the state health department and the regional and the local health departments so that they can look into that spike and investigate it. So we're helping that along through meaningful use. Also, we have the immunization registry measure,
Yes.
where it is a requirement now in stage 2 that all providers in our program hook their EHRs into our state immunization registry. And then electronic laboratory.
Lab reporting is important. We have, I think, close to 400,000 babies being born in Texas every year, and they all have to go through newborn screening tests. If that's another area where HIEs could be used, to activate the HIEs and enable electronic reporting. I mean, public health is probably a major driver of HIEs. And I think in Texas, we are lagging behind some of the other states, but we are trying to work more closely with our public health partners to get HIEs in that arena.
And I think you'll see some news about that within the next year. I know that we have at least a couple of HIEs that, from demand of providers, are working out connections with our state health department to where their providers can send their data through the HIE to the state health department.
Tarrant County has a syndromic surveillance for ambulatory, and recently there was a change in the city of Houston. They are wanting to wrap up, so folks that are in the region 6 and 5 South can talk to the city of Houston on the ambulatory side about wanting to participate, registration of intent for the syndromic surveillance.
Yes. Tarrant has the capability to do ambulatory, but they really don't have a lot of ambulatory feeds. Houston, I have heard, that they are going to start accepting the ambulatory feeds and actually putting them into their ROD system that they use.
I want to just thank Jason and Dr. Menon for participating in today's lunch and learn. We really appreciate it. You're welcome to stay and continue the questions if you have time. I'm just going to close the session for today, and I appreciate your presence and participation. Thank you, everybody.
Thank you for inviting us.
Thank you very much. It was a good opportunity to put together a generalized presentation, talk about everything that we do.
Thank you. We appreciate it. And very nice meeting you.
There was a guy who wanted to work with us. Okay.
Yeah.
Yeah, you put your other